Good afternoon, everyone. My name is Dr. Raquel Romero, and I want to be the facilitator for the ECHO session today. Thank you for joining our session number 2 of the Community Long COVID ECHO series. And we would like to start by providing a brief overview about the comprehensive long COVID care for underserved communities, innovative delivery and dissemination model project, as known as Comunidad, by Dr. Sabat.
Thank you, Raquel. And good afternoon, everyone. Again, welcome to a second session of our long COVID ECHO. Today, we are very pleased to have a neurologist, Dr. Sacco, present on covering long COVID topics in general, but with a specific focus on fatigue, post-exertional malaise, brain fog, and POTS. So without further ado, Dr. Sacco, please proceed.
Hello, everybody. My name is Ratna Sankala. Let me just give me a minute to just start sharing my slides. Let me see if, oops, there we go. Okay, can everybody see the slides?
Yes.
Okay, so my name is Ratna Sankam. I'm an associate professor at the neurology department at UT Health San Antonio, and have had training in autonomic nervous system, and that kind of made me come into the field of long COVID, and have the opportunity to work with the rehab team, Dr. Gutierrez and their team in the long COVID clinic, seeing some of these patients who have had significant neurological complications from long COVID, and also from some of these include autonomics. So I'm gonna just take next few minutes to review some of the neurology specific sequelae of long COVID, and that'll kind of help us lead into a case, and hopefully all of you all can participate, and we can have a discussion on how we can handle some of these tough cases in our clinical situations. See here, it's kind of okay. So these are my disclosures, but nothing in these have any relevance to this presentation. Again, a few more disclosures of from the ECHO group here, who we are doing this presentation as part of. So the definition of long COVID has been, there's been multiple iterations, but, in June of 2024, the National Academy of Science came up with this a little bit with a definition that it does suggest a few main things. One, it is a chronic condition that occurs after an infection with COVID-19, and it is present at least for 3 months, either as a continuous or a relapsing remitting or a progressive disease, and it can involve one or more organ systems. So this is kind of a diagnosis that, again, there have been a lot of iterations, but this is what we're trying to follow as to help us with the diagnosis and management. The landscape of long COVID has been filled, as I said, with significant uncertainty because of lack of clear diagnosis, lack of biomarkers. There's been a lot of medical gaslighting of this condition. Does it really exist? Because of the lack of these biomarkers. And then the management so far, what we have is based on what we have seen in the past with similar conditions. And it has been mostly rehabilitative with symptomatic therapies and improving functional performance of these patients. We're waiting on more studies that are going to hopefully give us more direction based on pathophysiology, because so far we have a lot of hypotheses, but not a proven direction to go with a lot of these patients. The neurological complications that we see in the long COVID are described in this picture, and as as we see, there are multiple presentations, a lot of cognitive symptoms, brain fog, executive dysfunction, with a lot of anxiety, depression, agitation, autonomic features. We think about palpitation, diagnosis of POTS or postural orthostatic tachycardia syndrome, orthostatic or otherwise hypotension, and some kind of temperature regulation issues with hypothermia, fever. We do also notice significant impairment in their activities, which include, though labeled exercise intolerance, I would actually say intolerance to a lot of activities, which may not be truly considered exercise in a regular day-to-day activities. So it does involve weakness, fatigue, exertional dyspnea, and it almost includes a lot of pain syndromes that are triggered by activities, which include like myalgia, especially post-exertional myalgia, and a lot of patients with neuropathic pain, paresthesias, and new onset or worsening headaches, and other neurological issues. The pathogenesis is still kind of not very clear. These are all the things that we think may be playing a role in the patients developing long COVID. There's persistence of the SARS-CoV-2 CoV-2 virus, reactivation of other viruses like EBV. There's also some antiviral responses that can trigger autoimmunity, and there's also in a hypercoagulable state with microthrombi that trigger these inflammation, which could be cytokines, chemokines, interferons that can affect multiple organ system, lungs, brain, neuromuscular, cardiovascular, kidney, to name a few. I'm going to kind of cover a few. I know there's a lot of symptoms that are associated with it. There are like top 200 plus symptoms that have been noted in patients with long COVID, but we're going to just focus on a few of those. The most common symptom that our patients complain is this fatigue, and they describe this as severe exhaustion even after minimal, and the activity could be physical or mental, and we kind of characterize that as diminished tolerance. So whatever they were able to do before the infection or before the onset of this condition, they are unable to do at this point. And they also report these frequent crashes. They feel good, and they do something, and then they have this crash where they're unable to do any activities, sometimes even ADLs, like they're bedbound for several days. And this fatigue does not respond to rest or sleep. It doesn't recover with sleep or rest, and they're continuously fatigued even after a good 8-hour sleep. What we recommend when we see this fatigue is to make sure we are looking for other normal causes of fatigue, because patients with long COVID can also have associated other features. So like make sure their sleep is intact. They don't have any other sleep disorders like obstructive sleep apnea, or that can be addressed to help improve it. Make sure they don't have like underlying endocrine disorders like hypothyroidism or adrenal insufficiency or hyperadrenalism. They don't have any cardiac that's triggering arrhythmias or respiratory disorders that is causing hypoxia. And the fatigue is not related to nutritional deficiencies like low vitamin B12, or an untreated depression or untreated autoimmune condition like lupus erythematosus or rheumatoid. But we're also seeing some suggestions that fatigue could be part of a mast cell activation syndrome, and we're going to talk about it in the next few slides. So the fatigue kind of almost borders into this post-exertional malaise, which is worsening of symptoms following even minor physical or mental exertions. And these symptoms can worsen even like 12 to 48 hours after the activity, not immediately after the activity. So what we recommend when we hear this, that I have crashes or I'm not able to do even anything that I used to do, I can't even do household chores, or I can't even drive my kids to work. We ask them to kind of keep a diary of what is causing these, so that we recognize what are the limits, energy limits of these patients. I almost tell these patients that, your energy is a bubble, and you want to kind of work inside that bubble, but occasionally kind of try to see if you are doing a little bit better. Even if you push that bubble too much, it'll burst and then it'll get into a crash. So maintain a diary of what you can do and what you cannot do, or what are creating these crashes, so you can titrate or change your activity level based on this. And also try to prevent those crashes, and try to get your there is an amount of time that you can do an activity, set an alarm to make sure you're taking those breaks and you're not inadvertently kind of pushing yourself too much to break that bubble. Management of fatigue is probably the hardest that we've seen in our clinics. There's a lot of these non-pharmacological management. We tell them pace yourself, plan your day, and prioritize. If you have a very important thing, like you want to go attend your kid's game, or you have an important meeting, then kind of make sure that you're resting before and not doing anything that's going to put you in a situation of crash at that important meeting. And also delegate or defer, or remove some of the things you don't need to do. Sometimes this fatigue could be related to other features we've seen in the long COVID, which is an orthostatic intolerance. So you want to see if there are other features that are that you can treat along with just treating these fatigue. In these programs, need to be very individualized. What it is not a one size fits all. So we kind of want to individualize each person's way they can deal with this fatigue, and also consider cognitive behavioral therapy, as that kind of helps you do all of the above that we talked about, like defer, delegate, plan, prioritize. So all of that can also be kind of trained, and you can make that a part of your daily routine. The pharmacological management could be many, and I think one of the things is a lot of these patients could be on medications that are making this fatigue worse. And some of these may have been started by us as a physician to see if there is something else going on. Like this patient has insomnia, so maybe we are providing something a little sedating at night to help them improve their sleep. But if that may be too much, and we may have to back off to help with the fatigue, and they may be on anticholinergic or antihistamine for mast cell instability. But if this is not working, or it's making the fatigue worse, maybe we need to pull back. So looking at the medication list is also important. And if there is suggestion that this fatigue could be part of mast cell, then we do think about referring them to immunology. So again, just to kind of summarize the treatment recommendations for both fatigue and post-exertional myalgias, we do recommend individually titrated rehabilitation that is slowly getting them to their previous level of functionality, and avoiding things that are causing these crashes. So kind of work at a submaximal capacity, and use energy conservation techniques like pacing, prioritizing, positioning to help you do any activity longer, and planning to inculcate those breaks or rest periods to avoid these crashes. Pharmacotherapy-wise, there's not any single therapy that has been tried and proven, no randomized trial that has shown as of now. Some of the medications that we are borrowing from other conditions that we have used it, like MS with fatigue or Parkinson's, or the medications listed like amantadine, modafinil, methylphenidate, low-dose naltrexone. Again, these are all borrowed from other conditions that we have utilized them, and there are smaller studies that suggest that there may be a role for all of these medications. Again, we do kind of want to make sure that we are looking at the whole picture of the patient. If you are giving them modafinil, maybe their insomnia is going to get worse. If you're giving methylphenidate, maybe their postural tachycardia can be worse. So you kind of want to make sure you're looking at their whole picture and making the right medication suggestion. Supplements have been used, but there is limited scientific data on the risks and benefits. So these are kind of, again, like a area where we just need more data, unfortunately, to be really clear about their benefits and risks. The other important thing that the patients can also notice is cognitive difficulties or brain fog. These are reported in about 80% or even more. Most of the patients I see do describe some amount of fatigue, the cognitive fatigue or brain fog. In the clinics, we often try to kind of objectively screen them with any of the available cognitive testing like Montreal Cognitive Assessment or Mini Mental Status or SLUMS. And again, just like what we did with the fatigue, we do want to make sure there are not any other features that are making things worse, like sleep, endocrine, psychiatric, or autoimmune disorders. So these evaluation would include evaluation for, anemia or B12 deficiency or thyroid dysfunction. Just similar to the fatigue, remove offending agent if they're on medications like antihistamine sedatives, medications for neuropathic pain like gabapentin or pain medications. Optimize the dosing to help the best response with the least amount of side effects. Sometimes we also keep adding these patients and without adding these medications without really evaluating if something is working, and just make sure whatever medication is not working is stopped or weaned off appropriately, so we are not increasing their just the medications that they are taking. Treat underlying conditions. Sometimes referral to neuropsychology is needed to help assess capacity to return to their workplace, and they are also able to suggest what kind of vocational rehabilitation or what kind of rehabilitation is helpful for these patients from the neuropsychological testing. And then they can also guide our therapy or rehabilitation based on what they evaluate. Is it more attention? Is it more executive function? So they can focus the treatments based on what are their major deficits. And these include speech and language pathologist, occupational, and some of the therapies that are even done by neuropsychologists. And just like the fatigue, these need to be individualized and structured. So the idea is to return them to previous level of activity. The other main thing that we have seen is the autonomic dysfunction, and this is autonomic is my area of expertise, and that's what brought me in to this long COVID. So autonomic nerves are the nerves that are working automatically beyond your cognitive function. So it's just automatically controlling your blood pressure, heart rate, your temperature control, your gastrointestinal genitourinary control. So because they're everywhere, the symptom presentation is encompassing multiple organs. So you can see cardiovascular symptoms like dizziness, tachycardia. You can see thermoregulatory with abnormal sweating, syncope, labile blood pressures, exercise intolerance. And sometimes because of this tachycardia and orthostatic, you do notice some cognitive dysfunction. The main diagnosis that we have been seeing in these patients is POTS, or the postural orthostatic tachycardia syndrome, which is defined by a 30-beat increase in your heart rate on standing within 10 minutes with a normal blood pressure. So this does not need a table testing. We are able to do orthostatic testing at bedside. You keep them supine for a couple minutes to get a blood pressure and heart rate, and then stand them up and do blood pressure and heart rate, make sure they're safe and they're able to stand and they're not at a fall risk. And you want to do at least 5 to 10 minutes to see if you're noticing that persistent 30-beat increase. And these 30-beat increase needs to be associated with symptoms of the orthostatic intolerance. And that's how we can diagnose them at bedside. And there is this NASA lean 10-minute stand test that also can be done at bedside to evaluate these patients. And again, the other features that we want to make sure we're not missing is other cardiac conditions like neurocardiogenic syncope, orthostatic hypotension, or inappropriate tachycardia. Because, as I said, autonomics are multi-system, we have seen GI dysmotility with fullness, gas, bloating, diarrhea, constipation, urinary retention, and dry eyes, dry mouth. And so a lot of symptoms that can come with with the autonomic dysfunction. A lot of times management, we do start with non-pharmacological methods like increasing electrolytes, especially salt, fluids, compression stockings, and recombinant exercises. Because they're orthostatic, we do recommend starting exercises in a laying down or a recumbent fashion, and then try to slowly increase to either sitting and supine. There are lots of medications that could help in these patients. These are beta blockers, alpha agonists like midodrine, mineral corticoids like fludrocortisone. There's also pyridostigmine, which is a cholinergic that can help improve your vagal function, improve motility, reduce your heart rate. And also this fuzzy sodium channel blocker called ivabradine that is also being recently utilized to help lower your heart rate without worsening your blood pressure. There is some data out there that talks about EECP, or what we call the flow therapy, enhanced external counterpulsation. This has been shown to improve the endothelial function by growing capillaries, and it can improve function to your vital organs like heart, brain, and kidney. Some data that suggests that it can improve fatigue and cognitive function in patients with long COVID, and it is being covered by some of the insurances, but it is a very time-taking process to go through, and a lot of our patients have improved with this EECP or the flow therapy. This is how it looks. It has like multiple cuffs that are sequentially inflating and deflating that creates this shearing force on your capillaries that causes growth or increased capillary formation, helping improve circulation. One of the things that we have recently learned more about during this long COVID is mast cell activation syndrome. It has been hypothesized that some of the long COVID can have symptoms that are episodic, that are triggering like allergic-like manifestations because of mast cell activation. And there is a workup that could be done, especially if they are having episodic flares, they're developing new onset allergies to different medications or foods, or just random rashes and flushing episodes. Those are when we do think about mast cell activation. The workup does include a few easily available testing like serum tryptase, blood counts to see if they have like eosinophilia, quantitative immunoglobulin levels to see if they have high IgE levels, serum chromogranin, and we can also do a 24-hour urine methylhistamine. Though these tests are available, often, unless you catch them during a flare or during an episode, they may all be normal. So I think normal does not rule out a mast cell activation syndrome during the evaluation. These are all the manifestations we can see from MCAS: headaches, syncope, presyncope, not just hypotension, but hypertension, paresthesias, tremors, seizures. People can have myalgias, myositis, elevated CKs, migratory arthritis. And it has been shown to coexist with hypermobility or joint laxity. So some of our hypermobile Ehlers-Danlos syndromes have a little higher propensity to MCAS. We're not quite sure how the underlying pathophysiology is for this. The management of MCAS, avoiding triggers, is identifying these triggers if there are any and avoiding them. Dietary interventions to consider like low histamine diet, and then comes all your antihistamines. And it's really important for us to make sure they're on both H1 and H2 blockers to try to act on the entire histamine pathway, not just H1 blockers. The medication that we also are trying to utilize that we borrowed from the ME/CFS or myalgic encephalitis and chronic fatigue syndrome literature is low-dose naltrexone. At these lower doses, anywhere from like 1.5 to 4.5 milligrams, it has been shown to have a partial agonist-antagonist effect in increasing your endogenous opioids, but also have an anti-inflammatory effect by acting on these toll-like receptors. So some data about anti-inflammatory and increasing your endogenous opioids, helping with that analgesia and improving your mood and fatigue. So in summary, it's a novel syndrome with a significant different presentations and no clear pathophysiology that makes it harder for us to diagnose and manage. It has been causing significant activity limitations and economic impact on our society. And we are getting some new guidelines on how to manage this, but still need a lot more studies to show which way to go and what directions to go. I do want to kind of pitch in to, and if you have a phone, please go to this QR code. There is a multidisciplinary collaborative guidance that was published with collaboration between multiple disciplines, and it is in PM&R, and it's an open access, and everybody can access these compendium statements, and they're really helpful for management of these patients. And these are my references, and I will stop sharing here so we can have some questions before the presentation.
Thank you,
Of
Dr.
cases.
Sanka. Thank you very much. Is there any question for Dr. Sanka in regards to this didactic presentation? You can unmute yourself or you can put it in the chat. Thank you. Thank you very much for the presentation and for explaining very well the management for medications and no pharmaceutical too. Thank you very much for that. If that's okay, let me just move on to do a brief introduction for our team. So would you please, for our ECHO team, unmute yourself and introduce us. I started your name. So I would like to start with Dr. Sabat is in the first one in the square.
Yeah, thank you. And thanks a lot for that didactic presentation, Dr. Sanka. Dr. Sanka actually provided a case for this week as well. So she's going to be presenting that, and then we can open it up for discussion on any of the topics that she talked about.
Yes, thank you so much, Dr. Sabat. We'd like to do just brief introduction of our team and Dr. Tregaria.
Hello, everyone. I'm a psychologist on the long COVID clinic team, and I assist patients with their mental and behavioral health.
Thank you very much, Dr. Mónica Verduzco Gutierrez.
Yes, hi, Monica Verduzco Gutierrez. I am a PM&R physician, and I here run our long COVID clinic.
Thank you very much. And for all our audience, Dr. Lisa Smith Kepela.
Hi, everyone. I'm Lisa Smith-Coppola. I'm one of the PIs on the grant, and here to support you all. Thanks.
Thank you very much. And for all of you that join our session today, I would like to ask you for our attendance records. Would you please enter your name in the chat and affiliation and the email address? This is again for our attendance records. And with no more from my end, I just would like to remind you that ECHO is all teach, all learn environment. So we encourage to participate in the discussion today. So with that, I would like to move for our case presentation. Dr. Sanka.
All right. Okay, thank you. So this is one of the cases that we have seen. Actually, we do run a multidisciplinary long COVID clinic that I participate in with the rehab. So we're trying to co-manage these patients. So this is 32-year-old female who presented to us with no significant past medical history and had her first COVID-19 infection in August of 2021, was a mild infection, no hypoxia or needing for hospitalization. And a few weeks, she did recover from it, but with no immediate symptoms. But a few weeks later, noticed this severe fatigue, unrefreshing sleep, and again, difficulty performing her job duties, both cognitively and physically, with episodes of postural dizziness and near syncope. She was also describing these episodes of flares that she couldn't, there were days that she would feel better, but days that were like really exhausting with inability to do any activities, along with the flushing and diarrhea, and increase in number of her near syncopal episodes. And again, there was no clear precipitating cause. In the clinic, briefly, her neurological exam physically was normal, but she did have some reduced scores on attention on MoCA, especially when we were asking her to list the, how many words can you list with the letter F in 1 minute. There were they were reduced in the number that we expected, and also trouble with the serial 7 subtractions. Her labs, though, were unremarkable. We looked for thyroid, B12, anemia, any of these things. In the clinic, we were able to do orthostatic testing, and her laying blood pressure was 106/72 with a heart rate of 72. And in 3 minutes after standing, she was significantly symptomatic with dizziness and shortness of breath. And her heart rate did go up to 116. So it was more than a 30 beat increase in heart rate, with no change in the blood pressure and symptoms of orthostatic dizziness and shortness of breath. So this orthostatic testing itself would suggest a diagnosis of postural orthostatic tachycardia syndrome. And with her constellation of symptoms, this cognitive difficulties, inability to do her prior job duties, unrefreshing sleep, and the severe fatigue. This constellation was suggesting that she did have a long COVID syndrome. And again, it was persistent for more than 3 months when we saw her. Can we go to the next slide? We did follow up again with just to make sure, because of her age and some of these symptoms, is there any inflammatory or a vascular condition? Her MRI was normal. She did have normal B12 and inflammatory markers. So nothing else to explain her symptoms. So first we did start with a lot of non-pharmacological therapies. We requested that she wear compression stockings, increase her fluids. Normally, we do say at least 3 to 5 liters of fluids, and increase electrolytes, which is mostly the sodium. We go up to 5 to 10 grams of sodium daily. And she was also sent over to the rehab to kind of help improve her cognitive function and occupational therapies. But then 3 months later, she comes back. She did have persistent symptoms, and it was harder to follow with some of the physical therapies because of her syncope and near syncopal spells, which and the physical therapists were noting that any amount of activity would push her heart rates to 130s and 140s. That was limiting their amount of activities that they're able to do for her in the rehabilitation clinic. So because of her current symptoms, and she did have a lot of fatigue, we did not choose a beta blocker. So we kind of went with this pyridostigmine, which is, again, as I mentioned, it's a cholinesterase inhibitors. We use it a lot in myasthenia gravis because it's a cholinergic. It improves the cholinergic supply to your muscles. So, but we also know that a lot of the preganglionic autonomic nerves and the parasympathetic nerves are cholinergic, and your parasympathetic is your vagal function to reduce your heart rate. So pyridostigmine can help reduce your heart rate without dropping your blood pressure, and it can improve the muscle fatigue, the physical fatigue that the patients feel. So that's how we started her on the pyridostigmine, with the thought that because she also has these episodic flares, maybe down the road we can think about some of the mast cell therapies, like H1H2 blocker or cromolyn or montelukast. These are some of the other things that we can use, mast cell stabilizers. So this is this is the case I have. I'm happy to take any questions. I know it's limited, like a shorter case. We still are trying to follow her 6 months down. She is better, but we're still kind of still having some more symptoms, not completely back to her baseline activities.
Thank you very much, Dr. Santa, for presenting this case. Now I would like to open this space for everyone to ask a question, make a comment.
This is Dr. Rosna. I was going to ask on this patient that looks like a lot of the symptoms are the chronic fatigue, almost similar to fibromyalgia. Do any of the other medicines that are used for fibromyalgia, like duloxetine and all those, do they ever try in these patients?
That is a good question. And yeah, we do utilize medications like duloxetine, sometimes gabapentin, pregabalin. The only caveat that we do kind of want to make sure is some of those can worsen some of the existing features of the fatigue and the cognitive difficulties. So I think have any medication we start we do start at a low dose and start with non-pharmacological first and then move ahead to the medications. We've definitely used a lot of fibromyalgia medications in this group of patients. I think I see a question in the chat to see if pyridostigmine can also help cognition. We have not seen that specifically to improve cognition by itself, but some of the cognitive function could be postural. We do often see that our patients with orthostatic hypotension or POTS have more cognitive fatigue when they're upright. They do better in a laying down position or a sitting position. So if there is that symptom, to just improve their circulation by reducing their heart rate and improving their blood pressure, we have utilized the pyridostigmine, but not directly because of the cholinergic effect, because this is more a peripheral cholinergic effect than the central from what you see with the medications like donepezil or others in that other cholinergics in that group.
Thank you very much. Is there another
I have a couple
question?
questions related to multidisciplinary team care, actually. The first has to do with referral to physical therapy for post-exertional malaise or post-exertional symptom exacerbation. You know, as a primary care provider, when we refer to PT in general for, you know, back pain, knee pain, whatever, we usually just say like, you know, please evaluate. But I wonder with these conditions, since they're so, you know, they're different in the sense that, you know, you really have to be careful with how you manage them. Do you give specific directions to the therapist, or do you, you know, kind of leave it up to them?
Yeah, so I'll give, since I'm in PM&R and kind of deal a lot with the therapy part, I will kind of answer some of that question. And so I think that, you know, there are certain therapy groups that I work with that are well versed in what long COVID means, but for the most part, I do have to give some direction for it. And one of the things that I'll put in there is that I want them to be screening for PEM or post-exertional malaise. Like, please screen for that, because the patient may go through a physical therapy session and, you know, be put on a treadmill and look like they're doing great. But then if the rest of the week they're in bed and they can't get out and they can't do any other activities, that's going to be very harmful for them. So and then the other thing, sometimes I will actually maybe either refer to PT or OT and have them focus on energy conservation strategies. So actually, you know, telling them focus on having them monitor their, you know, their energy and using their, you know, the energy envelope that they have for a day. And some of them will actually be taught things like oh, I can check my heart. And when my heart rate starts going up, I know that if I continue to do the thing, it'll go up, 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 and then I'll crash the next day. So it's also teaching them their limitations and how much they can do in a day. So again, OT can do a lot around energy conservation. But again, if you want to keep it simple, I want to keep it simple for everyone. It's like long COVID, autonomic dysfunction, screen for post-exertional malaise, kind of thing. And then for autonomic dysfunction, one of the big physical therapy things is there are POTS protocols. Like if you look, there have always been POTS before long COVID. But sometimes the traditional protocols, there's a CHOP protocol, a Dallas protocol, different ones are very aggressive for our long COVID patients. And sometimes I just want them to start on like breath work. And you wouldn't believe how much just breath work and like calming your autonomic nervous system helps tremendously.
Awesome.
And I think I just want to add that in these populations where there is a combination of autonomic dysfunction and PEMs, having that better an individualized protocol for therapy is important because pushing some of these autonomic protocols do push a lot that makes the PEMs worse. So just have to think about that and make sure the patient understands that, make sure that the therapists also understand that.
Great. My second question has to do with more with mental health aspects of these. And you mentioned, Dr. Senka, cognitive and behavioral therapy as one modality. But I wonder if, Dr. Tigrarian or Dr. Smith-Kilpel want to comment on other modalities, maybe acceptance and commitment therapy or the role of cognitive behavioral therapy in these issues.
Yeah, I'm happy to take that. So when you're dealing with somebody that has a chronic illness or a chronic disease, there's really 5 or 6 primary approaches, and one of them is CBT for chronic illness, and that helps people develop coping skills. It helps them kind of challenge their thoughts related to catastrophizing about their disease or their chronic illness. So, CBT is the three-legged stool, right? Your thoughts affect your behaviors, they affect your emotions. So if we approach it through cognitive restructuring, it might influence the way they behave and the way they feel about their chronic illness. The other one is ACT. And by the way, each of these different approaches are going to be deployed given where the patient is at any given time in their treatment. So if somebody receives a diagnosis of long COVID, they might be experiencing some grief and loss that this is going to change their life because they don't really understand what long COVID is. So there might be some grief and loss counseling there. They could be experiencing trauma from COVID or a long COVID diagnosis. So we might use some trauma-focused modalities. There's also motivational interviewing we would want to use to help them get ready for making some changes to assess their level or readiness for change. And then acceptance and commitment therapy is important too, because what acceptance and commitment therapy does is it helps orient people back towards their values and figure out how to make a life worth living, even with this chronic condition that they're experiencing right now. So, and then the last one I'd offer up too is CBT for insomnia. People that have trouble sleeping, CBT for insomnia there's evidence that supports that it improves people's ability to fall asleep and stay asleep. So, does that answer your question, Dr. Savat?
No, yeah, thanks. I appreciate that. Other people on the panel have any questions related to those things? Or from our partners?
I see a question in the chat. Is flow therapy meant to be short term versus long term for POTS? Thoughts?
Yeah, I'll take that. Again, the flow therapy, we don't have any indication for POTS by itself right now. We are mostly utilizing it for the fatigue and the cognitive brain fog symptoms. there are some of our patients who've actually had significant improvements and needed another booster later. So it's still kind of jury's out. Some people have gotten long-term benefits, and I'm gonna see if Dr. Gutierrez has anything to add, but we don't have data for POTS by itself, or we are not utilizing it for POTS by itself.
Right. Yes, agree. I
Thank
just
you.
was going to add one more thing to what Dr. Tigrarian said, was that one big thing that you can do for your patients is just, tell them, yes, you have POTS, you have long COVID. I said this at the last echo, and just really validate it. Because then when you say, oh, you're going to now go see a psychologist, then in their head, that makes them think you're not validating it. And no, this is a real thing. And then also you have to learn to live with a chronic condition. And that's where maybe this step comes in. Not that we think that you're making it up, because a lot of times, a lot of, also was brought up by Dr. Senka, that that patients feel that they're gaslit or that they have stigma against them.
Yeah, thank you very much. Validation for the patient says is very, very important. I remember you mentioning that. And thank you so much for mentioning it today. And with that, I would like to go to summary of the recommendations. Dr. Sabat is the lead specialist for the session today. Dr. Sabat.
Yeah, no, I just wanted to thank Dr. Sanka again for covering this really challenging and debilitating, these really challenging and debilitating presentations. We don't have a magic pill. We don't have a magic diagnostic test, but we do have various treatment modalities involving various disciplines, which is how we're setting up on Long COVID Clinic, to at least try to improve patients' quality of life. So with that, I think we're at time. I just want to remind everybody to fill out their evaluation. And we look forward to seeing you at next month's ECHO.
In June, next year actually, is going to be the June 8th is for our next session. And remember, ECHO
January.
is all January.
January, yeah.
Yeah, January. So next month, next year.
That's right.
At the 8th. At the 8th. And please remember, ECHO is all teach, all learn environment. And one of the elements is didactics and also the case presentation. If you are interested in the topic, please let us know. And also, I invite you to consider and present a case for our next session. So with that, and respecting everyone's time, thank you so much for being with us today. Thank you for our team. Thank you for the presentation, the didactics, and the case. And thank you all for being here today. And your opinion is so important for us. Please just complete that evaluation, as the Dr. Sabat mentioned, and I will see you next year.
See you next year. Happy holidays, everyone.
Thank you.
Bye-bye. Thank you. Thank you very much.